All right. Why don't we get started? So good evening, everybody. Welcome. Um, Dr. McGowan here with some of our True U team, Dr. Donnangelo, Dr. Maselli, Mary Cuthbertson, who's with our media and communications team. And we're talking about GFMA, which is gastric mucosal fundus ablation. And this is going to be initially we'll give some background and information, and then we're going to open up for questions. And please supply your questions. We want to hear everything from you. So in the Q&A box in Zoom, you can just type in your questions, and then we will field those. So punch away, put those questions in, and we will get to them after we provide a little bit of introduction about this procedure, which is really a brand new, very exciting procedure that we've developed here in our program, and we want to talk through all aspects. So let's go ahead and get started. And we're going to start with an anatomy lesson. I know everyone's excited about that. And we're going to talk about the gastric fundus, which is what this is all about. And here's a very basic illustration of the stomach. This is esophagus coming into stomach and exiting into the small intestine. And this little cap on top is what's called the fundus. Small area, but it does a lot, and it has two really important roles. And one of those is ghrelin, the hunger hormone. Everyone's familiar with this. It's what makes us hungry. It's what makes it so difficult to lose weight by dieting, because as we lose weight, hunger and ghrelin increase and combat our efforts to lose weight. So ghrelin is produced within the fundus of the stomach primarily, travels to the brain and tells our brain that we're hungry. So we'll talk more about that in a moment, but as a key role of the fundus. The other role, I'm going to turn to Dr. Maselli, has to do with accommodation. Dr. Maselli, you want to talk about that?
Yeah, I'd love to. I love this physiology stuff. So, yeah, normally when we eat a meal, within minutes, our stomach is going to rapidly expand to accommodate that meal, stretch basically, so we can fill that reservoir that is the fundus. And as we fill the fundus with the meal we've ingested, the interaction of that meal with the stretch of the fundus will signal from nerves from the stomach up to our appetite centers in our brain, something called satiation. Satiation is a sense of fullness or satisfaction that we get from a meal that leads us to stop eating. So as we fill up the fundus with that meal, we get a little bit more satisfied, a little full, a little satiated, we stop eating. So it has a really important role in regulating our food intake.
Thank you. Yeah, very, very important. Dr. Maselli loves satiation and every opportunity to talk about it, and we love it too. Let's talk about, so the deal with the fundus is it's regulating appetite, ultimately. That's what we're talking about here, via ghrelin production and via this accommodation. And previously, historically, until very recently, the only way to reduce ghrelin and accommodation is to surgically remove the top of the stomach or bypass it with a gastric bypass. And so we asked the question is, could we endoscopically reduce ghrelin and accommodation? Is that possible? That had never been shown previously. And we theorized that we could do this because ghrelin is produced in the inner lining of the stomach. So if we take a cross section of the stomach, it has four layers: the mucosa, submucosa, muscularis, and serosa. But it's the innermost lining, the mucosa, where that ghrelin is produced. That's where the cells live. And so conveniently, we can access that endoscopically. We don't have to do anything surgically. We can get into the stomach with an endoscope, and we're looking right at it. So it's a very convenient area for us to treat, but it had never been done previously. Ablation is used in a lot of areas of the body, so the concept isn't new. Ablation is the application of thermal energy, heat, to eradicate or treat tissue. And it's used in the heart if you have an arrhythmia. It's used in the endometrium of the uterus. It's used in the esophagus to treat conditions. And it's used in small areas in the stomach to treat small lesions. But it's never been used in a wide area and never to treat weight and obesity. But we had the hypothesis that this would be possible. And so we were the first center to conduct, we really treated the first patients, first humans ever with this technique. And that was what was called the ablate weight trial with 10 adults over 6 months. I should mention that prior to this study, we didn't just launch into this without any scientific backing. There was about a decade of science. It studies beginning in rats or rodents, larger animals, and leading up to this over about 10 years. So the key component to this procedure and the way we can do it safely is a device called hybrid argon plasma coagulation, or hybrid APC. And Dr. Donnangelo is going to explain what that is and why it's so important as I play this little animation.
All right, so here you can see the black thing is our scope. And the little blue tip is our probe. And basically what we're doing here is lifting that very innermost lining of the stomach up with a saline or fluid cushion to protect the deeper layers of the stomach. And then this little flashing you're seeing here is just a gentle burn of that very innermost lining. So Dr. McGowan showed the different layers of the stomach wall in the previous slide, and we're just isolating that very innermost layer with a gentle burn there.
Yeah, so very important that we protect the layers of the stomach with this fluid cushion. And so this device is really key. And that's why we're able to do this safely. But of course, we had to prove that it was safe, which is why we conducted this study. And now I'm going to show a procedure video after that. Now I'm going to show a procedure video of what this actually looks like in one of our patients. And so here we're going down into the stomach with an endoscope. And in the distance is that long part of the stomach below the fundus, and to the left is the top of the stomach. And so to begin with, what I'm going to do is use that same probe to mark the lower boundary of the fundus, kind of like the dotted line in that initial illustration that I showed. So I'm going to mark the boundaries and then proceed to ablate this entire territory. So we're just putting little dots here just as a way to mark the stomach. And then if we flip the scope around and look up at the top of the stomach, this is the fundus. And if I just look back here, this entire area is the top of the stomach, and that is the fundus. So the goal here is to ablate the entire lining of that area, okay? And so we use this probe, press it against the mucosal or inner lining, and then inject saline with a blue dye, methylene blue, and you can see the tissue just beautifully puffing up, and that's protecting the inner lining. So that fluid goes between the layers of the stomach and protects the deeper layers from any kind of heat or any injury. So now we're applying heat or thermal energy to the mucosal lining with this device, almost like zapping the lining. This is actually a really very advanced device. What is occurring here is there's a small stream of argon gas, which is being propelled through this probe towards the stomach lining, and then an electrical current travels through that argon gas, leading to heat application in a really controlled manner to the lining of the stomach. So what we're seeing is that normal healthy pink appearance changing to a white or very light yellow color. And that is telling us that we've successfully treated the mucosal lining of the stomach. And then that tissue will undergo very important changes as it heals. But here you can see section by section, we inject fluid for a safety cushion, and then perform this ablation technique, trying to get a nice uniform coverage throughout the fundus. And this procedure is performed under anesthesia, so patients resting, sleeping comfortably, and it's performed on an outpatient basis. So patients will come in, have the procedure, wake up, and then they can go home. So this is a completely same-day outpatient procedure. But you can see how we continue the process, applying heat to this lining with this device. And at the end, this is what it looks like. So that entire fundus cap has been treated, in this case, in about 30 to 40 minutes. And you can see the transition zone from fundus to the lower part of the stomach. So the entire area was successfully ablated. And so again, here's what it looks like before. And keep in mind, we're looking backwards. This is actually our scope coming out of the esophagus, and we're flipped around and looking backwards. The injection technique, and then the final appearance. Now, here's where the magic happens, because this looks kind of rough to begin with. I mean, it's essentially a burn. But 6 months later, let me just look, let's just enjoy what's occurring here. This is pretty amazing. And it was amazing to all of us, and probably one of the more beautiful sights that I've seen. And this is the fundus healing completely. So the mucosal lining heals, and it contracts and shrinks. And so you can see that the volume here is really small. So this area is tiny compared to where it began, and it can't stretch in the same way. So we've completely remodeled or changed that fundus via this technique. But it doesn't just look good. We can see on a cellular level, there are major changes. And so we took biopsies from patients before the procedure and then months after the procedure. And this is measuring the ghrelin-producing cells. We're actually staining for the cells that make that hunger hormone. And what you need to know is the little arrows on these darker colored areas are highlighting ghrelin-producing cells. And there's a lot of them before and very few after. So there's about a 50% reduction in the cells making ghrelin. But not just in the cells, we also saw that when we measured in the blood the level of ghrelin before the procedure, and then at 6 months, and many measures along the way, it decreased significantly, so 45%. It's a big reduction. So that's similar or nearly identical to what occurs with a surgical sleeve when the top of the stomach is cut away. We see a similar reduction here. And keep in mind that patients in this study were losing weight. And normally when you lose weight, ghrelin continues to go up and up and up. And in this case, it went down. So very compelling findings. We also then looked under the microscope at the tissue, not just at ghrelin, but also what other changes occur when we apply heat to tissue. And what we know is that it fibroses or toughens, and this fibrotic tissue forms, almost like scar tissue within that inner lining. And this is what's being highlighted in this type of stain. The bluer areas are what we call fibrosis. And so what that means is this tissue is stiffer and the cells have been replaced. Those ghrelin-producing cells are replaced by this fibrotic tissue, meaning the ghrelin cells are not likely to return in this area ever. That's a big deal. But it also reflects the stiffness of the stomach. And this is kind of fun. So we couldn't just ask patients how much they could eat. We wanted to measure it. And Dr. Maselli is responsible for introducing this into the study, which is a really important test, but not the most fun, because we asked patients to drink Ensure to maximum capacity, what we call Thanksgiving fullness. Drink it until you can drink no more. And before the procedure, the average patient could drink about 800 ml, so just under a liter of Ensure. And then you can see how it decreased. So by the end, and actually quite rapidly after the procedure, but by the end, patients can only drink about 460 mLs, which is a 42% reduction. So just by treating the fundus, we've reduced capacity by almost half. And that speaks to what Dr. Maselli said, which is that expansion of the fundus is so critical in satiation and feeling full. We also measured objectively hunger, appetite, and cravings, which all reduced. And then weight loss, the average weight loss was 20 pounds at 6 months. Now, this was a small study and there was a wide range. So we saw half of patients lost more than 10% of their body weight, and we saw patients lose up to 17% of their body weight in 6 months. That's a big number. But these are the results. Now, safety was the priority when we were conducting this study. And what we found is there were no complications, no major adverse events, and everything was mild. And that included abdominal cramping and nausea and gas, everything listed here. Some patients reported aversion to savory foods, meaning they were just less interested in those things. But there were no complications, which is very, very important in this first-in-human study. So that is a summary of the ablate weight study. What can we conclude? Well, we showed that this technique is safe and that it clearly results in, and all of these results were statistically significant, which is important. It reduced ghrelin, meal capacity, hunger, cravings, and it increased control over, or the ability to resist overeating. That's really important. And of course, it led to significant weight loss. So then you would say, who is this right for? Is it right for you? Someone who might be considering the fundus ablation. And this is an early study, but we've learned a lot, and we have many other studies ongoing, many completed, and so we have a generally good sense of where this might fit into our treatment options. One is ablation alone. So if you're somebody who wants to lose around 10 to 15% of body weight, which is where we estimate the average will land as we treat more and more patients, this could be an option. Keep in mind that's similar or essentially identical to weight loss medications like Wegovy, as well as to gastric balloons. So it could be an alternative to that. Someone who really wants to control hunger and cravings, this could be a good option. And the long-term impact is important. We don't expect that stomach area to change over time. And so we anticipate this will have a long-term impact compared to, say, a medication that you stop or a balloon that you remove. Another area to consider is combining the fundus ablation with the ESG procedure, endoscopic sleeve, which is our most common endobariatric procedure. And we are actively studying this and treating patients with these techniques. This is something we refer to as the ESG-MAX. And in this case, you have the restrictive sleeve of an ESG plus reduced hunger plus reduced accommodation. So the end result is much greater portion control and weight loss, which on average is exceeding 20 to 25%, if not higher. but results forthcoming, so that we conducted a second study called Ablate Weight 2, and we'll have those results in the very near future. What about somebody who's had a prior endoscopic sleeve and maybe is battling the head hunger and food noise, or needs a further boost? That is an option and something that we're also looking at. And then maybe someone who's not quite ready to take the leap to a sleeve-like procedure could consider ablation as a starting point, and that can be followed by ESG. So we have studied that as well. And we think this may have a role for patients who are currently or have used the GLP-1 medications like the Wegovy's, Ozempics, and are now either concerned about weight regain or control of hunger if they're coming off of that medication. And we do have a planned study forthcoming to evaluate that. So a lot of potential here with this technique. The key is we've demonstrated that it does have this really meaningful impact. And I will stop there with the didactic component, and we definitely want to answer questions. So at this point, I'll hand over to Mary, who's going to field questions from you all. Please go ahead and put all your questions in the Q&A box, and we will start answering them. Thank you.
Yes, thank you. We've got a few questions, but feel free to ask even if you think that it was answered and just want to go over it again. No questions are off limits. We'll start with this one. Can ghrelin, you say that ghrelin won't come back in the fundus area, but can ghrelin travel to untreated areas of the stomach?
It sounds like a good Dr. Maselli question.
Yeah, sure. So let's dive into some physiology. So Dr. McGowan mentioned that 80 to 90% of ghrelin is made up in the fundus of the stomach. So that means that some is made elsewhere. It's actually made throughout the rest of the digestive tract. So what we don't know for certain is there a compensatory response elsewhere? The ghrelin's not going to travel elsewhere, but the cells that exist elsewhere that normally make ghrelin, do they have more pronounced role after we get rid of the fundus? The true answer is we don't know. But if we look at analogous studies from the sleeve surgical literature, remember Dr. McGowan talked about how that surgery removes the fundus. What happens to ghrelin after a sleeve gastrectomy? Well, it doesn't really skyrocket up. There are some mixed data on that, but generally ghrelin stays low. So we don't expect there to be a tremendous increase in ghrelin over time, but this is of course something that we're going to continue looking at. Certainly we don't expect it from the fundus itself on account of all that healthy tissue getting replaced by fibrosis, by scar tissue.
Oh, Mary, you're muted.
I'm on mute again. Thanks, Dr. Maselli. I'll give the next one to Dr. Donnangelo. I have a couple questions about recovery. Does the scar tissue feel different after the procedure? And then how does ablation impact recovery?
That's a great question. The symptoms or recovery after this tends to be, pretty good for most patients. Symptoms are generally pretty mild. And so you can experience some stomach discomfort, like a little bit of bloating, maybe a little bit of cramping, but by and large, we don't see too much in the way of symptoms here. Compared to the standard ESG, it's about 3 to 5 days of, like I said, cramping, nausea, maybe a little bit of bloating, but usually pretty mild. It will obviously, we give all of our patients symptomatic medications to help with those. There are no nerve endings inside of the mucosal layer or that innermost lining of the stomach. And so I know, looking at those videos, patients could worry that, am I going to have pain from that? You're burning the lining of my stomach. But that's just really not the case. Like I said, we protect that deeper layer of stomach lining that contains nerve endings. And so we don't impact any nerve sensation there in the mucosal layer.
Awesome. Thank you. So I'll give this one to Dr. McGowan. We'll just rotate around. Penny asked, so if it takes away your hunger, will you have to make yourself eat? So will you, completely not be hungry or want to eat?
Yeah, we can't completely eliminate hunger. That would be problematic. And so what we're doing is diminishing it. And you could see from the results, we roughly nearly 50% reduction in ghrelin. It's about what we see. Now that's a powerful reduction, but it's not eliminating hunger. You need some hunger. What we've heard patients describe is, I feel hungry when I'm supposed to be. And I think that's a nice description. So if you haven't eaten all day, yes, you will have some hunger. That's important. But what you aren't likely to notice is the constant food noise that can be so bothersome. And so calming that down can have a really important impact. But yes, there will be some hunger. So nothing can eliminate it completely. But just diminishing it is very, very powerful.
Okay, thank you, Dr. Maselli. This is one we kind of went over, but just again, if a patient had an ESG, can they be a candidate later on for the fundus ablation?
Yeah, absolutely. An ESG is basically a narrower stomach, so there's some technical changes that we're going to keep in mind as the operators for this procedure, but the fundus is still intact after a traditional ESG, and we can access it much in the same way we would for a typical fundus ablation. So absolutely.
Yeah, just to piggyback off of that, what primarily inspired us to evaluate this was that we know the endoscopic sleeve, while a very effective procedure, is a little bit less effective than a surgical sleeve. And you'd say, why is that? We're making the stomach small, 70–80% smaller. Why is there a difference? And it probably relates to the fundus, because we are not able to remove the fundus with an endoscopic sleeve, and we're not able to drive down hunger to the same degree. So that was actually what spurred us to start evaluating this, and why we're now seeing with the combined effect results that are really rivaling a surgical sleeve. And again, we'll be publishing that very soon and talking more about it, but that's really what was the impetus.
Okay, thank you. I'll give the next question to Dr. Donnangelo. Someone asked, what was the age range of the participants in the study? And did anyone in the study not lose weight?
So everyone lost weight. And then in our practice in general, we perform these procedures on patients age 21 and older. So that's for all of our procedures. Yeah.
And because I have the study actually open right now, I can give you the specific age ranges for the 10 folks in the study. So it was 38 was the average, and it went 5 years in each direction.
All right, thank you. Dr. McGowan, someone asked, is the ablation after ESG available now? And then someone also asked, what is the cost of just the ablation? I'll let those go together.
Yeah, definitely. So we're at a point now where we've studied this enough and are very comfortable with the safety profile, the results, the technique. So we are offering this to really all of those categories of patients that I mentioned. Of course, we'd want to meet with you one-on-one and discuss whether it's the right option for you. I mean, that's always the most important thing. But from a technical standpoint, from a procedural standpoint, yes, we can offer this to patients who have had prior ESGs, or in those other circumstances where you feel it may be a good fit for you. Price-wise, currently is around $6,500 for the entire procedure program, everything related to it. But again, yeah, our team could discuss that with you in more detail.
Thank you. Dr. Maselli, Kathleen asked, what is the prep like before the procedure? And then kind of two-part. If they recently started a weight loss medication, would they need to stop before?
Oh yeah, these are great questions. So we'll tackle what do you need to do to prepare? So first you'd meet with one of us on the medical team, because we want to go through your medical history, surgical history, medications. We want to talk more in depth about the procedure and how it would apply to your life and your goals and needs. You'd also meet with a dietitian before you had the procedure as well, because we do have a modified diet that patients follow after we do any endoscopic weight loss procedure. And it's not really to induce weight loss, although that does happen. It's to help facilitate healing of the stomach. We don't want to put any stress or strain on a sutured area or a burned area, because we want that stomach to heal. So before a procedure, we'll have patients get labs. This is the same way for the gastric fundal mucosal ablation. There isn't a lot of prep in terms of dietary stuff, unlike with surgery, because we're not trying to shrink any of the anatomy outside of the stomach. So patients will be on a liquid diet the day before their procedure, and then they won't have anything to eat after around 7 p.m. That evening. Now, the second part of the question, medications, right? So if you've just started a weight loss medication. So this will be on a case-by-case basis. So we actually just put out a publication that shows endoscopic weight loss procedures are safe to perform while on a GLP-1 receptor agonist. That was just published in Obesity Surgery Journal. If you're doing the dose escalation phase of the medication, that might be something you want to discuss with us, because you can get greater symptoms during the dose escalation. And so again, we'd give you some advice on a case-by-case basis. But if you're on a consistent dose, you don't have any side effects to that medication, it's entirely safe to be on it while you have this procedure.
Thank you. Dr. Donnangelo, how does this procedure affect bone density?
That is an interesting question. And we do have studies ongoing in our practice looking at DEXA scans or quantifications of your bone density, your muscle mass and your fat mass, bone density, all that sort of all those metrics. But that is a question that we will need to answer in the future. We don't know at this point with this particular procedure. But yes, that'll be something we'll probably look into at some point with body composition type studies.
Awesome, thanks. Dr. McGowan, Anna asked, do patients notice a change in their hunger right away after the procedure?
Yeah, it's really interesting. If you look at that graph we showed of just ghrelin reduction and even the changing capacity, it takes a little bit of time, because what is happening is that tissue has to heal and then contract, and the lining has to change. The cells are changing. So it actually takes about 2 to 3 months for the full impact of the procedure. That's a good thing, because actually what's happening is we do the procedure and you feel kind of a little icky for the first couple of days, the first week or two. You're not hungry really at all in the beginning, and then things are healing, and then you're actually then seeing the impact of that ghrelin reduction, and so you get actually progressively less hungry is what we find, which is really fascinating, because it's the opposite of what we see with, say, just the regular endoscopic sleeve, where generally speaking, hunger starts creeping up after 3 to 6 months. So it's kind of a delayed effect.
Okay, thank you. Dr. Maselli, I think this is more of a technical question, but we got a couple people asked, what APC setting do you use for the ablation?
Yeah, it's a great question. We use a very low setting. So we're not trying to burn through, deep layers of the tissue. We're not trying to take care of any lumps and bumps. We're just trying to get rid of that top layer of mucosa. So we've experimented within reason with a couple different settings, but have landed on something that's quite low and quite safe. I guess that's what I'll say about that. It's a low wattage.
Thank you. Dr. Donnangelo, someone asked about side effects in the stomach after the procedure, if there were any.
Yeah, so that's a great question. We touched on that a little bit earlier. So typically 3 to 5 days of kind of mild stomach upset. So bloating, cramping, maybe a little bit of nausea, but mostly just feeling full. It tends to be extremely mild. We give our patients medications to treat those. As far as effects in the stomach, really just that over time, we'll see that scarring down or that contraction, that fibrosis, which impedes the stretch of the stomach and leads to, helping you feel full. So, but no major long-term effects on the stomach. We actually use argon plasma coagulation or APC frequently to treat other gastrointestinal conditions inside the stomach. And so long-term, the technique is safe.
Awesome, thanks. Okay, next question for Dr. McGowan. What is the reduction in the stomach capacity for the ESG-MAX procedure versus just the fundus ablation?
Yeah, thank you. By the way, thank you all for these questions. This is really actually a lot of fun. And we're getting into a lot of good detail. So if we see about a 45% reduction in capacity with just the fundus ablation, when you add the ESG, we've actually studied that. And again, we haven't released those results yet. But then when we're doing that same Ensure torture test for maximum capacity, it's reduced by, it's around 75 to 80% reduction. I mean, a very drastic reduction in capacity. So in terms of ounces, patients were drinking around 40 to 50 ounces down to like 10 ounces is the maximum tolerated amount they could drink. It's a very big reduction. So if you look at the volume reduction of an ESG by itself, it is about, once things settle in and relax and heal completely, maybe 70%, 80% reduction in volume. But then you add that fundus reduction, and it's probably an even more significant player in this.
Awesome, thanks. Okay, Dr. Maselli, I had a couple questions that were similar, but a couple people asked, what happens to the treated area that's ablated? Does it just peel off and pass? And can it come back?
Yeah, it's good. It's a great question. So those cells, we use the word slough off. So they kind of die and then they sort of fall off and then regenerate and heal into that really nice, beautiful picture that Dr. McGowan showed of that 6-month fundus. It's contracted down, but it's that nice pink, healthy tissue over it. So it goes through a healing phase for a couple of weeks. And that's really important to be aware of because that is the period when patients could be vulnerable to the risks, though rare, of this procedure, including ulcers that could bleed. So a related question that I'll sort of lasso here and then answer is, what are we going to do to help facilitate that healing and minimize risks associated with that healing phase? So it's all about preventing ulceration or managing ulceration if it were to occur. So our patients after gastric fundal mucosal ablation are on 2 separate medications to help facilitate healing of the stomach: an anti-acid, really anti-ulcer medication that lowers stomach acid, and then a coating medication to keep that area nice and safe. In addition, we ask patients to avoid risk factors for ulceration, like tobacco and non-steroidal anti-inflammatory drugs like ibuprofen, Advil, Motrin, those kind of meds. In that period of time when we're extra cautious, extra careful, really trying to get our patients and ourselves to be diligent about reminding our patients about that period is about 12 weeks. That's the amount of time we really want to be strict and stringent about protecting the top of the stomach.
Awesome, thank you. Dr. Donnangelo, a couple people asked this question. For someone who has had an ESG and eventually added a GLP-1 medication to maintain progress, would the ablation fully replace the function of the medication?
That's a great question, and that is a future direction that this procedure could definitely go. So, for a lot of reasons, the GLP-1 medications are great. Some patients don't want to be on them long term, and so, like we had talked about earlier, the weight loss just from the gastric fundus mucosal ablation alone is very on par with things like balloons, medications, and other weight loss therapies. So certainly a possibility in the future as a bridge for patients to eventually come off those GLP-1s.
Thanks. Okay, Dr. McGowan, someone asked, does the fundus ablation, especially with ESG, increase the risk of GERD like a surgical sleeve? Since you have less.
Thank you. Something that we definitely were aware of, that potential. One reason that we don't see acid reflux after an endoscopic sleeve, in theory, is that fundus cap is kind of untouched, and it's an area where acid can kind of sit and not come up the esophagus. But there's really more to it, and more other reasons why we don't see reflux after an ESG. And what we've learned through these studies is that we're not seeing acid reflux. And in fact, patients who entered our studies with acid reflux, I think universally have been able to come off of medications or reduce medications. So that's really promising. It is one thing that we're tracking, but we're not seeing any real indicators that it increases acid reflux.
Awesome, thanks. Okay, Dr. Maselli, can the body find a way to regenerate that mucosa over time after the ablation?
Yeah, so good question. So the mucosa does regenerate, heals over. That's why you get that, you don't get this, kind of continuous ulcer there. You get this nice pink tissue, again, from that endoscopic view that Dr. McGowan showed in the earlier slides. Now, maybe another interpretation of that question is, does the ghrelin-producing mucosa regenerate over time? And not insofar as what we saw in the context of the 6 months of this study. Those ghrelin-producing cells were reduced by about 53% and were replaced by scar tissue. And scar tissue is really dead tissue. It doesn't regenerate, it can't make ghrelin. So our hypothesis, and again, this is something we're going to look at 12 months out, 18 months out from these procedures, is that ghrelin would remain low, particularly ghrelin produced by the fundus.
Thank you. Dr. Donnangelo, we had some questions about just the whole process for someone out of state and downtime. So can you go over someone asked, what's the time frame from consultation to procedure day? How would it work if you're from out of state? And one other question kind of related was, how long would I need to take off of work?
Those are all great questions. So we do frequently see patients coming from out of state, even sometimes out of the country. So you see us in consultation. The soonest we can typically get folks in, by the time you get your labs done and we get all of our ducks in a row for your procedure day is typically a week or two. And then you have your procedure done, and then symptoms can last for about 3 to 5 days. So patients are typically back to work in about that time. And there was one more part to that question. Can't remember the last part.
It was just how would it work if someone's coming from out of state?
Okay, so logistically, we will, help you with all these details when we talk to you in consult, but we do have hotels that are nearby. We'll help you with transportation, where to stay, and all those sorts of things. So this is not something that we are a stranger to at all, and we can help with all those details.
Yeah, I think knowing that they'll meet with you virtually beforehand too. The procedure day, I guess, is that the only day that they'll have to come and be in
Yes,
person?
that's important. So we obviously need to see you on procedure day to have your procedure done. And then the following day, we also require that we see you in clinic. So you come back to the same place you had your procedure done for what's called hydration. It can sometimes be difficult to get a whole lot of fluids down that first night because, your stomach's a little bit swollen. And so we'll give you additional fluids. We'll go over your procedure report, give you any additional medications through the IV that you might need for symptoms. And then after that quick hydration appointment, it's usually 30 minutes in the morning, the day after your procedure, you're free to go home. And so those are the 2 times we see you in person, and then all of your follow-up from that point on, all virtual. So the aftercare program is very, very important. I know we've talked about that in previous webinars. You'll meet with our nutrition team to learn how to, work with your new stomach to really maximize your weight loss, and of course have medical follow-up throughout the rest of the year.
Thank you. All right, Dr. McGowan, is hydration needed post-procedure like it is with the ESG? And will I need to follow a liquid diet or the diet progression again?
Yes, we do recommend and really basically mandatory. We have you come back the day after so we can check on you and to hydrate you. And it's not as challenging usually to meet your hydration goals after just an ablation, but we always want to avoid dehydration because you just feel terrible if you start falling behind in your liquids. So yes, we're going to be really proactive about that. And the general diet progression is pretty similar to our other endoscopic procedures, our other weight loss procedures. So a roughly 2-week liquid phase and then advancing onward through soft foods and regular foods. So very similar approach.
Thank you. Dr. Maselli, how well does the fundus ablation reduce cravings?
Yeah, this is a really good question. So, we talked a lot about ghrelin being reduced, but how does that actually, play out in real life? So you have your anecdotal patients telling you, it really has muted. There was a lot of our patients in the early experiences told us it's like turning down, a radio dial from all that food chatter. But this isn't just something we, want to impart anecdotally. We actually have good data that tell us about these cravings, and there are validated questionnaires that we can use when trying to interrogate the patient has improvement in appetite measures. Things like the Daily Eats questionnaire, something called the WellSF questionnaire. And when we measure things like hunger and cravings and confidence in the ability to resist those cravings, all of those measures improved over the study duration by basically about 50%. Now, it's hard to know how that quantifiable amount translates into patients' daily life, but there was absolutely a measured and statistically significant improvement in all of those measures of appetite control.
Thank you. The next question to Dr. Donnangelo. Someone asked for a patient who is 1 year out from the ESG and is thinking about a ESG revision, would ablation alone address the issue, or should they consider revision plus ablation?
That's a great question. So both are certainly options. We would obviously go in, assess the stomach, see how tight things are, and then make a decision there. But typically, we would try to do both, so suturing and the ablation as well, but it's really a case-by-case basis situation. So we look at that particular patient's procedure, what their trajectory has been, examine the stomach, and make that call. But certainly both are possible.
Thank you. Okay, Dr. McGowan, can we treat a patient with fundus ablation who has a hiatal hernia? Might be.
Yeah, hiatal hernia, but right. So, which is a common internal stomach hernia. So we haven't specifically studied this, but given that we have not seen any acid reflux occurring after this technique, this should be certainly absolutely a possibility and should be perfectly safe. And we've actually treated some patients with very small hernias, but I think a small to medium-sized hiatal hernia would not be a problem. Technically, of course, we can do it. The bigger question is it going to cause any issues? Are you going to have more reflux? What's interesting is as we treat that area, which is so close to the esophagus, everything tightens down. So in theory, it could actually help with some of those symptoms, I think. And we're going to, let's start planning that study right now too, team. But I think, it really is, it would be safe, but something we'd talk to the individual patient about.
Thank you. Dr. Maselli, someone asked if they're out of state and their primary care doesn't know anything about this procedure, but they have to go in for readmission. How would that be handled, or has that happened?
Oh, sure. Great question. So you're getting at, we manage people not just locally, but from far and wide. And what if one of the, rare complications happens from an endobariatric procedure? So yeah, a couple different things. So the first is every patient who has a procedure with any one of these physicians you see in front of you has that physician's direct cell phone number. So that's so that we keep in constant communication, whether you're, down the street in Cary in Atlanta or whether you're in, Portland, Oregon. So we'd want to know if you're having any concerns about any symptoms. Now, if you were to have a very rare complication, by the way, the risk of complication from an endoscopic weight loss procedure is less than 1%. What we'd want you to do is to give us a call, and then we'd walk you through the next steps, which typically would mean going to an emergency room and getting managed there. And we're able to conference in with any physicians who'd be part of your care team and help manage from whatever distance you might be from us.
Thank you. All right, Dr. Donnangelo, someone asked, is there any stomach pain right after the ablation?
Typically, no. So again, there aren't nerve endings in the lining that we're ablating. All of that is protected under the fluid cushion. Discomfort is possible. So again, we treat that with symptomatic medications afterwards. And in general, our practice is we don't prescribe any sort of narcotic or opioid pain medications for any of our procedures because our patients just don't experience pain. So in general, I know watching the video can sometimes be a little bit jarring, but that is really nothing to worry about. You should not have pain.
Thank you. Okay, Dr. McGowan, someone asked, is there any reason someone should not get the fundus ablation, or who would not be a good candidate for this?
Sure. Yeah. So contraindications to having the procedure is really the question. So there are a couple things. If you're a smoker, if you smoke tobacco, you would not be eligible unless you are completely tobacco-free for quite a period of time, because that affects the health of the stomach. Really, reasons we're looking at are things that would prevent your stomach from healing properly, because we don't want you to get an ulcer. So smoking, that's a definite no. Ongoing use of ibuprofen, aspirin, blood thinners. If you cannot stop them, you would not be a candidate. And keep in mind that it takes about 2 months, maybe even a little longer, for the complete healing of the stomach lining. So if you're someone who uses those types of medicines routinely, you'd have to stop them for that amount of time. So that's something to consider. Otherwise, if you're in generally good health, you're a candidate for this. There's no real medical contraindications to this procedure.
Thank you. Okay, Dr. Maselli, is this a one-time procedure like the ESG, or would you have to come back for another?
Yeah, well, that's a great question. By the way, just as an aside, the questions have been really good tonight. You guys are doing your research. So our suspicion is that this would be a one-time procedure because, again, harkening back to the biopsies that we took and then stained for fibrosis, this procedure generates a burn that gets replaced by scar tissue. So that scar tissue is not regenerating into healthy tissue. It's ostensibly something that's really durable, we would not anticipate it to need to be repeated over time. But that said, as a caveat, a little cop out here, this is an early experience. And so we're going to continue looking at this month after month, year after year, as we build our awareness and education around this procedure.
Okay, thanks. Dr. Donnangelo, have any participants reported weakness or exercise intolerance due to reduced intake?
Not to my knowledge, no. So most people do really, really well. And you're able, sometimes, you can experience a little bit of fatigue or low energy while you're on the liquid portion of the diet progression, but that usually passes really quickly. So, yeah, not to my knowledge, have we had that happen.
Okay, Dr. McGowan, can fundus ablation be a rescue method for those who have had an LSG and regained weight?
Oh, that's timely question. All right. Well, so a couple aspects here. A properly done surgical sleeve involves removal of the fundus, but not all surgical sleeves are performed the same. And some surgeons, maybe who aren't, for whatever reason, may not remove that top of the stomach. And so that could be a reason that someone who's had a surgical sleeve either does not lose the normal amount of weight or the expected amount, or has weight recurrence, or is hungrier than expected. In that case, we absolutely could treat that area. But we are actually just about to launch a study looking at ablation of a vertical sleeve, so post vertical sleeve weight regain, treating it purely with ablation. And so I'd say stay tuned. We'll be launching that hopefully in the very near future. So instead of suturing the stomach, which is our current technique for reducing a surgical sleeve if someone's regained weight, we are going to explore purely ablation to have some hormonal effect, but also to completely remodel that sleeve. So taking a dilated sleeve, ablating it so it shrinks down and narrows into a much smaller sleeve in a very controlled way without suturing or any other intervention. So we will be announcing that really soon in our North Carolina and Atlanta centers. So stay tuned. We're actually really excited to see the impact that will have. In the meantime, though, we do offer endoscopic revisions with suturing, and our standard approach is to use an element of ablation to help the sutured tissue fuse together during that procedure. So that's our standard technique that we currently offer, and it's one of our more common procedures.
Okay, thank you. Dr. Maselli, another surgery question. For a patient who's had the lap band, if they wanted to do the ESG-MAX procedure, is this an option? And would they have to get another surgery to remove their lap band before they come down?
Yeah, great question. This is awesome. So yes, the short answer is yes and yes. So we can perform the ESG-MAX in patients who've had prior procedures on their stomach. ESG, we've talked about, lap band with removal. If you had an intragastric balloon and have had that removed and have seen weight return and hunger return subsequently, good candidate for ESG-MAX as well. So we do need that band removed, though. It would pose a risk at the site of ablation for ulcer or deeper injury. So yep, we would have to have that removed, and we'll coordinate with you and your surgeon as to the appropriate time to perform the ESG-MAX afterwards. But you would still be a candidate as long as that band were not present.
Thanks. Okay, Dr. Donnangelo, someone asked, what was the weight range or the BMI of participants in the study?
That is a good question.
I have those data.
Okay, good. I can tell. Hold up.
So the inclusion criteria for the study were BMI 30 to 50, right? So patients could be in that range. The average BMI was 40, and it went 5 points in either direction. So most patients were about 35 to 45, but you were allowed to be 30 to 50, and that's actually generally where in clinical practice we're also offering this procedure, give or take a little in either direction.
Okay, I'll give you this one, Dr. Donnangelo. Do you have to follow any specific pre-op diet?
No specific pre-op diet, except for clear liquids the day before, and then nothing by mouth that night. That helps clear your stomach out so that we can see everything well. But as far as some people have in their mind, that like Dr. Maselli mentioned earlier, the pre-surgical liquid diet to kind of shrink the external organs so surgeons can see around in the abdomen. We don't need that. We're directly visualizing everything in the stomach.
Okay, Dr. McGowan, other than this procedure, is there any other way to reduce ghrelin?
No. That's the real innovation here. Surgically, as I mentioned, yes. If you surgically remove stomach tissue, there's less ghrelin, or bypassing it with a gastric bypass. But you know that if there was a pharmaceutical way to do this, it would exist, because that's where all the money is invested, is in medication treatment. And the fact is, there is no drug therapy. There's no medication way to reduce ghrelin. It just doesn't work. So really, that speaks to the significance of this. I mean, let's just take a step back and consider what was achieved here. You know, we entered this with it was a complete unknown. Would this procedure do anything? Who knows? We didn't know. In fact, many smart people said to us, it's not going to work and it's probably not safe. And that's why we studied this in a very rigorous manner with registered clinical trials. We had amazing patients who took the leap with us and said, let's try it, you know, let's do this. And we studied it and just took a step back and let our patients follow through the study so we could see that end result. And we saw the reduction in ghrelin. And so really, that's never been shown with a non-surgical procedure. There are some other techniques that are in the exploration phase that are still procedure-based, trying to knock out the blood supply to the top of the stomach, which is not as directed and probably not going to have a major role. But yeah, this is the only way. And the beauty of it is it's safe. So we want to preserve that safety. Our number one priority always is safety. Obviously, we want our patients to lose the most weight, but we have to do it in the safest way possible. But yep, this is a completely new technique.
Awesome. Yeah, someone asked, I guess this answers this question, but someone said, is this procedure one of a kind, the newest on the weight loss field? So it sounds like yes.
It's a completely new territory. And maybe that's the most exciting thing. You know, where can we take this as a field? We're defining the techniques here in our program. And the nice thing is, now that we've demonstrated that, we're collaborating with other centers around the world who are further helping to refine these techniques so we can really have a standard for the field. It's not something that can be offered by other centers yet. You know, this is still is under investigation, but it really is an entire new frontier in the treatment of hunger and weight. So obviously, we're very excited about that.
Awesome. Okay, Dr. Maselli, someone asked, do you recommend the ablation without ESG? So who would be a good candidate for just ablation?
Yeah, that's a really great question. So truly the most effective procedure that we currently offer is that ESG-MAX, the combination of the restriction from the ESG plus the restriction and ghrelin reduction from the ablation. But you know, as Dr. McGowan phrased it, like, what if you're not really prepared to take the leap towards the suturing component? You know, what would make the gastric fundal mucosal ablation kind of a suitable, you know, approach, a suitable path for you? Well, there's a couple different answers. I think the first is hunger your main problem? So this is a procedure that targets the hunger hormone, the only known hunger hormone actually in our bodies, ghrelin. And it does so really effectively, safely, and feasibly. So if hunger, cravings, food noise, you know, if these are part and parcel of your challenges with weight and weight loss, this is probably a really good option for you, even independent of the sleeve. The second would be, you know, what are your weight loss goals in terms of the actual percentage of weight that you're looking to lose? Is it in that 10 to 15% range? Because that's where we estimate this gastric fundal mucosal ablation technique to land. Again, similar to balloons, similar to Wegovy in terms of the absolute weight loss. If you're looking for something higher, 20, 25+%, then we more strongly recommend the ESG-MAX procedure.
Thank you.
Yeah.
Dr. Donnangelo, is the procedure beneficial for someone with type 2 diabetes?
Yes, so the answer would be yes for that. We know that any meaningful amount of clinically significant amount of weight loss, somewhere between 5 and 10%, can improve weight-related medical conditions like type 2 diabetes and high blood pressure, high cholesterol, all of those different conditions. So certainly, yes.
Dr. McGowan, someone asked how many of these fundus ablation procedures have been done so far?
Yes. Okay. So The Ablate Weight 1 study was 10 patients. That was the absolute first in human study. The Ablate 2 study, which was the first combined study of ablation with ESG, was another 10 patients. We have a couple of registries up and running, and we're treating patients outside of those clinical trials because we've proven the safety. We've moved beyond those very regimented clinical trials. And so at this point, we've treated, I believe, upwards of 50 patients with the fundus ablation technique. And I also mentioned that we're using the same techniques for really most of our surgical revisions at this time, including gastric bypass revision, the vertical sleeve revision I had mentioned. We're using that same device and technique. So in total, we've treated hundreds of patients with this technology. But it's really important for not just us, but for the field that we really continue to study these procedures. And that's why I mentioned these registries. So a patient who comes to us and says, I'm really interested in having a fundus ablation, we're going to ask if you're willing to participate in that registry. It's not really asking anything of you other than we're going to anonymously collect data in a prospective manner so that we can then share with the world, okay, well, here's the average weight loss, not with 10 patients, but with 100 patients or whatever number. And then we'll have a much better understanding of what that average is. And we can really pin that down. So really important, and also looking at safety as we treat a larger number of patients.
Thank you. I think we have time for a couple more questions. Dr. Maselli, I'll go to you. Someone asked if the scarred tissue, will it feel different to the patient after the procedure?
Yeah, great question. So a couple different answers to that. Like, will you notice it just kind of hanging out during the day? The answer is no. This is entirely inside the stomach, so it's not affixed to any component of your abdominal muscles. You're not going to feel a tug or a pull. Now, when you eat, it will feel different because that fundus is less compliant. It's more rigid, more fixed. So when you eat, you get full a lot faster because that fundus isn't expanding. So while you eat, yep, it'll feel different, better, improved in terms of appetite control. During the rest of the day, you won't notice any difference.
Okay, Dr. Donnangelo, another question about a good candidate. Is someone who just struggles with the hunger hormone and food noise a good candidate? Someone who's already lost weight with a weight loss medication, but they just really struggle with the food noise?
Yes, so that would actually be a great candidate. So this again is targeting the hunger hormone and helping with food noise and helping with cravings and that sort of thing. And it's okay if you've already lost some weight. It's okay if you're on a weight loss medication like a GLP-1. This GLP-1's receptor agonists work on that hormone, GLP-1, and this works on ghrelin. So they have different mechanisms. And as you lose weight, your ghrelin levels actually go up because your body wants to maintain balance. And so patients who are already actively losing weight can sometimes struggle with plateaus and cravings and a lot of hunger. So this is a great procedure for anybody who's dealing with any of those things.
Great, awesome. Do we have time for one more question, Dr. McGowan?
Let's do one more. We are at 9 o'clock, as I've mentioned at every webinar. Sleep is important. You can't tell from my virtual background. I'm actually supine in bed right now. You actually can't tell. But no, we will wrap up. Let's take one more. I see there are some other unanswered questions. So anything that we didn't get to, we can answer afterwards or maybe on social media tomorrow. But thank you all for joining. Please reach out to us if you want to meet with us directly. You need further questions answered. You want to talk to our team. Definitely reach out to us. And I'll take the last question and then we'll wrap up there.
Okay, awesome. What is the amount of weight loss with the ESG versus ESG-MAX?
Yeah, so we haven't released the study results from that Ablate Weight 2 study. So I can't give you a definitive answer. It is significantly higher though. And tracking in line with a surgical sleeve. So what we're estimating is in the 25 to 30% total body weight loss for an average with the ESG-MAX compared to our historical average with a regular ESG of between 17 and 21% or 23% with a regular ESG. So there's about at least we think for most patients, a 5% plus bump in total weight loss. That's really important. It's shifting that average up by that amount can have a major impact on health. And again, really is essentially in line with a surgical sleeve. But as we treat more patients, we'll have a better understanding of what those exact numbers are. Okay. Good stuff. Thank you all for joining us. This has been a really productive hour. And again, reach out to us anytime to talk to our team, to meet with any of us or our other medical providers. And otherwise, I hope you all have a great evening. Thank you.